I get a confirmation whether the audio is working? Thank you. Hi, everyone. We're going to get started here. We're just in the process of finalizing the PowerPoint presentation, and it'll appear shortly. In the meantime, it is my pleasure to welcome everyone, and thank you for joining us today for our Lunch and Learn session. It's the first one for this year. My name is Gilbert Custari. I am the Director of Advancement with the Lawrence Bloomberg Faculty of Nursing, and we're pleased to be hosting our Lunch and Learn session, which is part of the Advancement Office Alumni Engagement Initiatives. Today, we will learn about how simulation is being integrated across the undergraduate nursing program here at Lawrence Bloomberg Faculty of Nursing, and how critical simulation is supporting the development of entry to practice competencies, critical thinking, and clinical reasoning for nursing students as they prepare for the realities of current practice. Before we get started, I would just like to acknowledge this land on which the University of Toronto operates for thousands of years. It has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous peoples from across Turtle Island, and we are grateful to have the opportunity to work on this land. Before we get started with the presentation, just want to make sure we cover a few housekeeping items for today's event. To start with, since there are a significant number of us attending, I would just kindly ask that you stay muted throughout the presentation. You are more than welcome to enter your questions in the chat box as the presentation is happening, and we'll ensure that during our Q&A period after the presentation, we will answer any questions you may have. Also, just to note, this session will also be recorded so we can share it with those that were not able to join us today. We will make sure to send an email after the session, which will include the link to the recording, as well as an opportunity for you as a participant to provide feedback on today's event. I would now like to introduce our today's speaker, Erica Cambly. Erica is an associate professor in the teaching stream here at Lawrence at Bloomberg Faculty of Nursing. She completed her Master's of Nursing degree at the University of Toronto in 2005. Erica is also a Canadian Certified Nurse Educator and is working towards the Canadian Certified Nurse and Simulation Educator certification through the Canadian Association of Schools of Nursing. Erica's teaching interests include using gamification and simulation to enhance skill acquisition and competence development for undergraduate students. Erica regularly presents this work at conferences pertaining to teaching and learning for healthcare education. Thank you so much for taking the time to present with us today, Erica. If the presentation is ready, you just get a thumbs up so we can pass it on to you.
Thanks, Gilbert. I think our technical glitches are solved. Let's keep our fingers crossed and hope. I'm going to go ahead and share my screen, and then we'll get right into it. How's that? Can everybody see that? Fantastic. Thank you so much for inviting me to share our work here at the Bloomberg Faculty of Nursing. It's really great to see so many people are interested in this particular topic. As Ilber said, my name is Erica Cambly. I'm an associate professor in the teaching stream here at the Lawrence S. Bloomberg Faculty of Nursing. I use the pronouns she and her. And I teach in the undergraduate program, and I'm currently the lead of our simulation program in the undergraduate program. So I've been asked to talk about how we use simulation with undergraduate students. During this presentation, I will provide some background to our sim program, as well as information about our current use, and also talk about some of our future priorities. We had the terrific pleasure of having a recent renovation project in our lab, so I will give you a tour of the lab through PowerPoint. I wish I could bring you all in and wander you around, but that's not possible in this particular day. Just have to make you little, there we go. So our program here at the Bloomberg Faculty of Nursing is a second entry 20-month program. So the majority of our students come in with a degree in anything at this point. Many have master's degrees, and sometimes we have also students who are PhD prepared. So they're quite a diverse group of learners. In the first year of our program, they have several clinical experiences, and they attend clinical practice really quickly into the program within the first month of the program. And these include working with older persons, working with people experiencing mental health issues. And then in the second half of the first year, so currently, and from January to June, they are rotating through pediatric, adult acute care, and postpartum settings. In year 2 of the program, the clinical experiences include acute care, which could be pediatric or adult care. They spend time in community practice, and they all go through a final integrative practicum where they are placed in all kinds of settings. They may be community, they might be pediatric, NICU, ICU, adult care, a whole range of experiences. So that's just a little background around the clinical component of the program. And they, of course, at the same time are taking other foundational courses along with it. When we think about simulation, what do you imagine? Maybe you think of mannequins in a lab. Maybe you think of virtual games. Maybe you think of aviation simulation or flight simulators. Maybe you think of those old sim people that we used to play with on our computers way back when. We can really think of simulation as a technique rather than a technology. It's a pedagogical approach that uses one or more typologies to promote, improve, or validate a participant's progression from novice to expert. We might see simulation being in a low, medium, or high fidelity, and fidelity is the how close to real the simulation experience is. They can be in person, they can be virtual, they can be hybrid, so a combination of one or more or with more than one type of simulation. And I just want to point out that this slide was adapted from the Canadian Association of Schools of Nursing simulation course. I've taken the 4 modules and they're wonderful. So if anybody has an interest in learning more about simulation and its development and facilitation, I encourage you to look into this, if not this course, then perhaps some other ones. So when using simulation, participants experience a representation of real events. And that's a really important thing to remember. They have opportunities to engage with a wide range of clinical situations. As educators, we can tailor these experiences to the level of learner. For example, what we would expect an early or first year student to do in the lab would be quite different than what our expectations would be for someone reaching the end of the program. We can develop experiences in the lab or in virtual environments so that students can care for a range of patients or clients. We can work through high risk, low frequency situations that they may not get to see in their clinical practice settings. For example, we can engage them in simulation related to a postpartum hemorrhage so that they can see what the signs and symptoms of that, how to recognize these, and then what to do about it. And that's really the important piece to maintaining patient safety. We can also have them experience what it might be like being involved in a code blue or cardiac arrest, so that they get some experience in that area before they graduate and are potentially placed in that in their clinical settings as a nurse. Exposing learners to complex patient conditions and including appropriate debriefing might help them develop critical thinking, clinical reasoning skills, which can contribute to the development of good clinical judgment that they can use in real life practice. Simulation encourages they get real feedback during the simulation, and they can also participate after the simulation. So they're getting reflecting in action and reflecting on action. So during and then after, so that we can really promote, hopefully, some very deep learning. When educators are planning to include simulation in a program, it's really important that we identify the gaps. How will simulation make a difference? And in fact, will it make a difference? As I said, it's a pedagogical approach and not necessarily the right approach for every gap that we see. So I think that's really important to consider. Having students come into the lab just for the sake of using the fancy lab and the fancy mannequins is not the best approach to simulation. It really we need to be making a difference. We also need to ask if we have the necessary resources. Do we have the staff to help manage the lab, and do we have the equipment? And this would be true also with virtual. Do students have the equipment needed to run the simulations on their computers or their phones or whatever? Do we have the expertise to develop, facilitate, create simulations? So that's an important question as well. In 2021, the International Nursing Association for Clinical Simulation and Learning updated their best practice standards. The healthcare simulation standards of best practice is what those are called. These documents are really they're really great in terms of thinking about a simulation or a simulation program and how we're incorporating best standards. They've looked to the literature, to great research that's been done by simulationists from around all over, and incorporated this into these best practice standards. These standards help educators understand what needs to go into a simulation to ensure that it's a positive learning experience for the learners. It's important that we develop clear learning objectives, that we have goals, and that these are tied into our program or our courses. We incorporate theory when we're designing simulation-based experiences, and there are a few out there. The National League for Nursing uses the NLN Jeffries simulation theory, which is a great one to look at if you're new to simulation or continuing in simulation, to help with the design and also the evaluation of simulation-based experiences. Templates can be really helpful in terms of simulation design, and there's some really great ones out there. The CanSim organization has some great templates that they use. And again, these templates have been designed by simulationists who really understand simulation and are incorporating these best practice standards. Another best practice is to include a peer review with content experts and to include some sort of pilot testing with a sample group of the participants that you're anticipating. I put this model, the clinical judgment model, has sort of been gained a lot of attention in the last few years, and this is a model that was developed by Tanner and offered out in 2006. And this is has been taken up by the folks who developed the licensing examination, for example. And Tanner talks about these areas of noticing, interpreting, responding, and reflecting. And we can see fairly easily there are some newer literature that's actually using this model to evaluate simulation learning and the learning that happens during simulations. And you can see how simulation can really fit with this model. Students come with a background information and within a particular context, and we can have them come in and work with mannequins or even virtually with the patient on a virtual environment. We expect that they're going to notice some cues. So we provide very specific, well thought out cues. We anticipate that they would notice. So let's take the example, one that we use in one of our foundation courses is we have the example where the patient is complaining that they're having some difficulty breathing and their oxygen saturation shows that it's low. So we expect that the students will be able to notice these things, and then they start to interpret these, and they're brand new very early on in their nursing education, but we expect them to see that, oh, this oxygen saturation is not within the normal expected limits for this patient. And they start to interpret these results that they're seeing. They're listening to the patient, which is great because we can get that patient's feelings and perspectives in there. And then they start to think about how they're going to respond to these cues. So they take an action or they do some actions. Maybe they put the head of the bed up. Maybe they encourage deep breathing and coughing. Maybe they do some more assessment, think about, get some more information from that patient. And these are all things we can do in simulation. And then the nice thing is they can start to see some of what happens when they do these things. So if they put the head of the bed up, did that help ease this patient's breathing at all? And maybe it did, maybe it didn't, depends on what our goals of the experience are. And they can start to think about and reflect in action. So thinking about how are their actions, what is it doing? And do they need to think about doing any different actions? And then at the end of the simulation, we bring them back into the group and we have them reflect or debrief in our debriefing period. And this is the reflection on action and how they can take this new learning and this practice into future clinical settings with actual real patients. So this is sort of how we can think about this model. And it's just one that we can use in simulation. And as I said, there are others that are very good as well. Another consideration is typology and thinking about, we don't always need to pull out the big fancy mannequins. You can see in this picture, hopefully, there's a picture of an arm with a blood pressure cuff on it. And this is a tool that we use early on in the foundational and the fall course. And one of the things that students told us when they were trying to do a manual blood pressure on a patient or on their peer partner in the lab, they don't really know what they're listening for. So maybe they've had some theory or they have had some theory about blood pressures in the classroom setting. And then we can bring them in the lab. They can feel the pulse on this arm actually. So they can find the pulses, they can put the blood pressure cuff on, they can pump it up and they can let it out and the sounds will actually come out through the speaker. And this helps them know what they're supposed to be hearing when they're doing this with a real patient. And we found this is really helpful to integrate into the lab because then we ask them to go to their partner in the lab and to do a blood pressure or practice blood pressures with their partner before they even go into the clinical setting. And then we encourage them to practice blood pressures in the clinical setting as well. So this is sort of how we can scaffold the learning throughout different components of the program. We might use screen-based computer simulation. We can use virtual reality, which is sort of a newer thing. We can embed them actually. We've used the Google Glasses to give them a sense of what the patient's experience is in getting things done, to them by nurses. Haptic systems allows some feedback in the form of what we feel. Standardized patients or embedded actors can be used in our simulations, and we tend to our embedded actors are generally the students themselves. We have roles for learners playing the role of a friend or family member in most of our simulations. And we have quite a few advanced patient simulators that are fairly sophisticated, and some are not as advanced and some are more advanced. So really just thinking about the types of equipment that we're going to use and how it will impact the learning and how is it getting us towards those learning outcomes that we're trying to achieve. When we think about a simulation experience, we can think about three distinct parts: the pre-simulation preparation and briefing, the clinical scenario, and the debriefing experience. Now, some folks are separating the pre-simulation preparation and the briefing component. They are somewhat distinct, but I'll talk about both of them. But the INAXL or the standards of practice that I spoke about earlier have them as one piece. So I've kept them as one piece. When we think about pre-simulation prep and briefing, we include the pre-sim can happen even a couple of weeks ahead of time. So these might include course notes and lectures, things they're learning in the classroom. We might include some virtual simulation. We might have quizzes. We have some simulations where they do a pre and post quiz so we can evaluate if the learning outcomes are being achieved. The briefing really takes place right before the simulation in our program. So this is an orientation to the space, the equipment, the simulator. If they're going to be evaluated, and in most cases they are not receiving any summative evaluation, it's more of a formative evaluation, what the roles might be in the simulation, how long we are going to have our simulation and debrief, the objectives of the simulation, and then we give them some information about what is going on with the patient or client. And this is often in the form of a nurse handover, often using ISBAR, or they might have chart notes, or they may even have a video of a nurse talking and giving them a handover report. We always include a fiction contract, and this is really important, where we acknowledge that there are limitations to the realism of simulation. At the end of the day, these are mannequins, the family members are themselves. And so we need to establish that fiction contract and encourage them to immerse themselves in the learning and speak to the patient as if they were a real person. We also go over if there are any ground rules, and these are things like confidentiality. We used to say what happens in the sim lab stays in the sim lab, and I think a lot of sim programs have used that line, sort of the Vegas rule. We've modified it a bit because we will talk about how individual performances or words or thoughts will stay in the sim lab, but we take the learning with us out into the world of clinical, because ultimately that's what we want to do, is to translate this into real world practice. After our prep work and our briefing, we engage in the simulation, and our in-person simulations are often about 10-ish minutes long, and then the debrief is longer. It just really depends on the simulation. We do one in the final course that is a bit longer, but really depending on sort of what are the outcomes. And we have set and specific cues that we provide students. These might be given over the vital signs screen that you can see on the one side of the page there. In our birthing simulation, it's the baby is born. So that's sort of the end of the simulation there once they've the neonate. So we always have different triggers. We have different moments during the simulation that tell us what point we're at, what cues the students need, and when it's going to end. In the center picture, that's a picture from a virtual simulation that was created. And in those, we have decision points. So a student would be going through these independently, potentially coming to a decision point where they have to make a choice about what they're going to do next. And then based on that choice, the simulation will advance. They may be cued to say that's not the best choice, and then they'll go back a screen, or they may make a correct choice and then they can move forward. In some cases, virtual simulations are set up so that if they make an incorrect or not the best choice, it will continue on so they can see what would happen if they made that choice. And learners seem to like that, according to the literature, and they will go back and purposefully make the mistakes to see what will happen, and that helps them with their learning. Our clinical scenarios, again, always important to have clear goals and objectives at the learner's level, and then a clear clinical scenario or a story. An unfolding case study, some have called these. Consideration to the roles. They should align with practice. So if we're using PPE in the practice setting, we should be using PPE in the lab setting, for example. And we integrate best evidence and best practice. And the resources I've listed, the first one is the Anaxel, with the best practice standards. The other three are all Canadian, which is really lovely. So CanSim, I've mentioned earlier, Simulation Canada, and Toronto Metropolitan University has some really interesting simulations, as well as resources for facilitators. The debriefing generally in the program takes twice as long as the simulation itself. Facilitators should be skilled in the process and an expert in the content. In our program, we have a sim team who give the skill of facilitation, but we don't all have expertise in all of the content areas, obviously. For example, I will facilitate pediatric stimulations, even though I'm not a pediatric nurse. But in those cases, it's important for me to have somebody with me who has expertise in the content. It's important that the facilitator has actually seen the simulation, and that sounds maybe kind of silly, but what I mean by that is that if we're running the simulator, some of them are quite complex. And so running the simulator, you're not getting a sense of really what's happening. You're getting the patient perspective perhaps, but you're not seeing the whole picture of what's gone on in the simulation. So having two people as facilitators, we see different things during the simulation, which is great. Using an established debriefing method, and there's quite a few. I've put there three of them, and there's so many more. And I think what's important is using the debriefing method that fits the simulation. What's going to be the best support for the learners? What fits most or best with whatever type of simulation you're using. And always important to support confidentiality, openness, self-reflection, self-analysis. And this will help engage students with not only the simulation, but also in the debriefing. We could spend probably days talking about debriefing and debriefing strategies. I'm doing it in 2 slides. I encourage you again, there's lots of good resources out there around debriefing. So if this is an area that you're interested in, go to the literature, look for courses, watch webinars. There's some great free or inexpensive resources out there. These are the kinds of questions that we ask. We use an advocacy inquiry approach in our debriefing questions. So we bring students back to the table areas in the lab, our debriefing areas, and we start with eliciting their emotion. How did it feel? And often simulations can, there's a deteriorating patient or there's some kind of something else that's happening that can bring up a lot of emotion. So allowing them time to let those out and just talk about that is really helpful. And then they can move into what was the learning that happened. We listen to them, help them understand the scenario, what was going on here, and we can often uncover some assumptions during that time. We use, again, an advocacy inquiry model. So something like, it seemed really chaotic when the patient's condition started to decline. How did you know who was in charge at that point? So those kinds of questions. We also use a lot of I wonder questions. I noticed this, and I wonder what might have happened, what you think would have happened if you had done this. It just helps to make the questions a little less threatening. We always ask them to move situation to practice. So we'll ask, has anyone in the group encountered a patient who has had this issue or who has deteriorated, for example? So we do that. We think about what are the lessons learned. And we also talk about we always at the end of our simulations like to go around the table and everybody says something that they've learned and how they will take that into practice, because realistically, at the end of the day, that's really what we want to impact is patient care. It's fine to go through and do a wonderful job in a simulation, but if we can't pick that learning up and use it in real practice, then we've missed a step here. I mentioned we are using more and more virtual simulations. We can also think of these as serious games. And again, they do include the pre-sim prep, briefing, simulation, and the debrief. The picture I'm showing is one called Responding to a Medication Error, and this one is available through the CanSim library of simulations. And this is one that I've included in my lecture in the fall term of the first year when I talk about medication safety. and giving medications. And you can see that this particular simulation was written by members from the University of Manitoba and the University College of the North, and then also with the members of CanSim. And this is really great because this is actually, as a member, as a contributing member, because I've worked with this group as well to contribute to simulation within this environment, I can access these and use them with our learners. And it's really lovely, I think, in simulation. One of the great things is a willingness to share resources. As I said, there's a lot of actual free resources out there, which is just so wonderful when you're using Creative Commons licensing, and more students can benefit from the use of these resources, rather than everybody trying to invent their own products. And this was a real thing, really took off during the height of the pandemic, when virtual simulation was really took off because of the challenge with having students in clinical practice during that time. At the University of Toronto, in our undergraduate program, we have an undergraduate simulation team. It's currently 4 members strong, 4 faculty, and then also 3 teaching assistants. So each faculty member gets a course release for the delivery of the simulations. We also have the course instructors of the various clinical courses, or faculty advisors, as in the final course of the program, that come and help with the simulation as well. They really act as the experts in the different areas. We've also started to encourage and invite adjunct faculty to come in, and many adjunct faculty, and perhaps even some of you watching today, have had invitations for some of our more specialty areas. And this is a way of giving back to the faculty and being involved in the faculty, which is also really wonderful. And we really welcome these adjunct faculty to come in and share their expertise with students. We've also sometimes had other content experts. So these might be practicing nurses or clinical instructors if needed. We also have the benefit of having a simulation lab coordinator, and he is responsible for overseeing sort of what goes on in the lab, the scheduling, the work of the lab assistants, who are undergraduate students whose job they often come and they are setting up and tearing down and doing all that kind of good stuff. And our simulation lab coordinator sort of orders the equipment, make sure we have all the consumables we need, make sure we have everything we need, and coordinates any training, that sort of thing. So he's an invaluable member of our team. And the IT team, I didn't put them in there, but they also help us out a lot with running the mannequins at times, or making sure that the software is updated and that sort of thing. So as I mentioned, we use a bunch of different things when we're using simulation. This picture is of one of our wound care lab in the first year. And you can see we have all kinds of wounds set out, their body parts, not attached to any person there, but students here will learn sort of the assessment piece of the wounds, as well as some of the dressings they might see in practice, that sort of thing. And then they have the opportunity to work with a mannequin who has a wound somewhere on their body. And so we have them work with the mannequin to dress the wound and learn this sort of technical aspect of how to do a wound care dressing. And then we have them do a project where they're actually videotaping. So they're really creating their own simulation, videotaping themselves, uploading it, and providing some reflection about that. So it's really a project that takes in a lot of components of simulation to do. And that's in our first, one of our foundation courses. We have had students come in and work through simulations as part when they needed some remediation or some practice with additional skills, as they were needing some help from the clinic, identified from the clinical instructors or from the clinic settings. We have used simulation as preclinical preparation. So before they even head out into some of our clinical courses, for example, the community course, because that's really a different environment going into someone's home, and some of the health teaching that has to happen. So they come in before the clinical even starts to make sure that they have some background knowledge before they go and work with real clients. We use virtual simulations in many, many of the clinical courses, and occasionally a student is unable to come into one of our live in-person simulations, and so we can complement their learning with virtual simulations as long as they're meeting the expectations or the learning objectives that we have set out for the in-person simulation. And then, of course, we have students come in for a 2-hour session in each of the clinical courses. And these might include, for example, in our medical surgical course, which we're having them come in tomorrow, they'll be spending 2 hours. They'll go through both a medical situation as well as a surgical situation, recognizing that students, some are in medicine units, some are in surgical units. So this allows them to experience a range of conditions and a range of different clients. Okay, so here's a fun part. So we just, as I mentioned, we just had the opportunity over the past couple of years during the height of the pandemic, actually, to renovate our lab. Part of this renovation, the impetus for this was recognizing that patients are going out into the community and they're more unwell potentially, and we're not always able to provide all of our students with home visits or a lot of community visits. So we actually were able to embed a nicer apartment that we can use with a full bathroom, and I'll have pictures of that. But I'll just go through these pictures and show you just some of our lab. So I said we provide learning opportunities to more than 500 U of T nursing students every year. Our undergraduates, we've got just under 200-ish in the first year of the program and about 180 maybe in the second year. So there's all the undergraduate students come through the lab and they use it quite extensively. We also have other programs. So we do have nurse practitioner, the MN, the DN, and the PhD programs. And they, particularly the nurse practitioner program, when they have their residency weeks, they use the lab, and the MN program come in and do simulations as well. And I think my sense is that they're thinking about how the graduate programs might engage in simulation in the lab more frequently as well. And there's just some different shots of students and some of our equipment that we have in there. We can configure and reconfigure. We're creative in the sim team and figuring out how to create environments that, again, are mimicking or as close to real as we can get. So you can see we have the head wall with all of the equipment there, and we can rearrange the lab. Everything's movable, so we can rearrange so that we have the space or a simulated space that we need. This is our new apartment, and the handy thing about this is that this is actually a Murphy bed, which was clever, so we can pop it up if we need to use more of a living room space. So it serves that dual purpose, or we can bring it in, make it into a kitchen if we needed to, that sort of thing. It also does have, and I don't have a picture of it, but there is also a full bathroom. So if we needed to do some assessments using the bathroom, we can do that as well. And this was one of our newly renovated spaces. The other piece that was added and enhanced as part of the renovation is our community clinic room. And this is a great space, particularly for the nurse practitioner program, where learners can come in and work within a clinic space. We also use it in the undergraduate program when they're learning maybe to do well baby visit or other types of community practice in a clinic. Many of our students have their clinical placements in family health teams, so this might be a place where they can practice some of that skill. This is a shot from the opposite end of, well, actually there's one picture from each end of the lab. In the main part, our west lab, we used to call this our low fidelity lab, but we usually refer to it now as our west lab because it's at the west side of the building. And it features 11 beds that we can reconfigure, we can move them around, we can do all kinds of stuff. And it's really just, this is a really well-used space when we are helping them practice their health assessments, for example. The East Lab is a smaller piece of the lab, and it has 5 beds that can be rearranged again. Both of these sides we can go into, we have a control room in the middle, and we can run the mannequins from the control room. We can speak through the mannequins from the control room. So the person running the mannequins actually doesn't even need to be in the room anymore, which is great. We also have an isolation room, and this was created back in the SARS days, if you remember that health crisis, and also comes in handy when we are now thinking about various conditions that patients might have, and encouraging students to think about isolation room and providing care and what PPE they might need, what conditions they might need to change this or that PPE. So this is a very well-used space. It is a one bed space, so it's nice if you're going to work one-on-one with a student. It's a great space to use. Each end of the lab has a debriefing area, and all of our bed spaces can be accessed through video, and we have very good video capability as well as sound. So students could actually be sitting in the debriefing area and watch a simulation that's taking place at the far end of the lab through just the cameras in there. But we do use these spaces generally for our briefing and our debriefing areas. The lab is also attached to a classroom that's across the hall, so we can actually project into those classroom settings as well if need be. We have medium fidelity mannequins, and we have lots of task trainers that we use for different reasons. And again, you don't always need to use the big expensive heavy mannequin. Oftentimes a task trainer or a more basic mannequin is perfectly good in developing some of those fundamental nursing skills. We also have a number of high and medium fidelity simulators, and these guys can give feedback. They can be connected to monitors. They can be run remotely. They don't need to be plugged in for long. They can be out of the plug-in for long periods of time. So these are really useful. Their downfall, I would say, is that they're incredibly heavy. So moving them around is not, even side to side in the bed, can be challenging. And here's a few examples. There's one of our medium fidelity simulator. And at the top, you can see that the nurses are doing CPR, and we can actually hook our mannequins up so that they can get feedback on the quality of their compressions, the quality of the breaths, and all of those sorts of things, which is kind of a handy feature. We have child and infant simulators, and these are helpful in caring for complex pediatric patients. Some worry a little bit about going into a pediatric setting. Maybe they haven't worked with babies or small children, and so we can give them some confidence in that. And just another little pictures about some of our 3G simulators and some of what the computer interface looks like when we're running these guys. We've just had just a little bit about our program. We've recently, over the past couple of years, been really taking a hard look at our program learning outcomes. So we really have a great opportunity right now to further develop clear strategic plans for a simulation program and making sure there's clear linkages to the program outcomes. And it's just, the timing is just fantastic right now. We continue to develop and seek additional simulations to fill gaps. So we're currently working on a bit of a needs assessment right now to see where the gaps in the program are, so that we can fill these gaps in clinical practice or working with specific client populations. It's over the past couple of years, I think there have been more nursing seats added across Ontario. There have been challenges with health human resources in our healthcare settings, and these have the effects of making it more difficult to secure clinical placement. So in some cases, and maybe instead of going 2 days a week, students can go 1, which is great, but we want to be able to enhance that learning a little bit within our sim lab. We've also taken a good hard look at all of our simulations to ensure that inclusive language is used and that our simulations are representing diverse populations. And that's something that's been really important to us as a team here. I'll outline a few of our simulation activities. As I mentioned, our foundational nursing course, we continue to integrate more and more simulation into the different into the foundational course. So rather than just learning how to do something, we try to embed it within a patient experience. We've learned a lot of lessons when teaching online during the height of the pandemic, and so we've been able to keep some of those things that worked really well. Some of the virtual simulations that were developed or some of the resources that were developed, we've been able to continue using those, and that's freed up time to bring in more hands-on simulation into that course. We recently, one of the teaching assistants on the simulation team, who's a graduate student in the NP program, came to me early this fall, saying that he was really interested in developing a simulation for the undergraduate students. And he was particularly interested in working in the patient, having the patient as part of the Two-Spirit LGBTQ+ community. So with another faculty member and me, he was able to develop the trans home care simulation, which we have included as a pilot study at this point, or a pilot, not a study, just a pilot simulation. And this included pre-simulation preparation, which consisted of some readings and a recorded lecturette. We were able to have this simulation once developed. We took it back to members of the trans community to look at it and provide us with feedback, which was a really important piece to ensure we were using an appropriate language, appropriate perspective. And we really took a gender affirming approach with this particular simulation. We invited students to come in and have for a 1-hour in-person experience where they were able to go into this patient's home. So this was a person who'd had top gender affirming surgery and had been discharged back to their home. They had a lot of questions around the surgery. They had drains in place. They had surgical wounds. And it was great because it encompassed a lot of different elements. So not just the post-surgical care, but also working with the person in a gender affirming approach, working with a trans person, also caring for any of the drains and so on, as well as going into someone's home and some of the challenges associated with going into a home as a nurse. So we were able to bring all of that into this experience and had a positive debrief. The students who participated in the pilot were able to provide feedback through Google Forms at the end, and they gave us some ideas for future simulations, future iterations of this particular simulation, and it was overall a very positive experience. Some of my colleagues have been working with the Faculty of Pharmacy to develop a module that pertains to opioid poisoning. One component of this module is a simulation where the participants find the patient who has a suspected opioid poisoning. This simulation also, as part of the bigger module, which also has people from the community who are persons who use opioids come, and so students are learning from community members and people with real experiences as well. So it's quite an innovative project. I had the pleasure of providing some feedback about it from a simulation point of view, and it's really quite great. And they're doing some interesting research study with this particular simulation. A few years ago, recognizing that students had a interest in end-of-life care, and you can't predict if a student is going to have the opportunity to care for a patient who is dying within the program. So we created the end-of-life care curricula, where it again has some prep work, some time in the lab about care of the body, care of the patient who's dying, and care of the body after death. And then they experienced a simulation, and we were able to run focus groups and get some further information from the learners about how we could improve this particular simulation. And then COVID came along, so we haven't done it live with bigger groups, but it's something that's still in the works. And I also had the pleasure of working with Simulation Canada and had a virtual project where they aimed to develop many simulations, and they were able to develop in the first round, over 100 virtual simulations that are available through Creative Commons licensing, again, so they're shared widely with whoever feels they would benefit their students. So that's a really great resource. And I've also worked with CanSim to develop virtual simulations, which is another simulation group. And I think I'm right in time here. Simulation can take many forms. Effective simulation-based experiences are developed and delivered in a thoughtful way using standards of best practice. We continue to explore opportunities to include SBEs across the programs. And out in the simulation world, research continues, an exploration of the impact of different modalities and different ways of simulation. Examination of components of simulation, which pieces make a difference or make the biggest impact, and best practices in simulation, preparation and delivery, facilitator training needs, and participant needs. So thank you for listening, and I will happily take questions for the next, 5 minutes or so, I guess.
Thank you so much, Erica. Really appreciate you taking the time and sharing with us this information. Very informative and helpful. We do have a question. In the interest of time, we want to make sure we get as many responses as we can. So we have Lori asking about, are you looking at the end-of-life bereavement for pediatrics and perinatal?
I don't teach either pediatrics or perinatal, but I did have a conversation with the professor who's teaching the perinatal this year, and they do have one of the core classes in the course is looking at bereavement for childbearing persons. She has, I know, a guest speaker coming in who that is her area of expertise, and she's also coming into our lab to help us with our perinatal simulation that we run. So I know it is being looked at, and I can't speak with any more authority on that one. Yeah, Barbara, I can see, I'm just looking, Ilber, at the questions. So this year last year, we started a de-escalation simulation when we worked with the mental health. In the mental health course, it's actually not necessarily a person who is experiencing mental health crisis, but rather someone who is experiencing an escalation in an acute setting. So recognizing that people can be in crisis or be escalating or be worried across all healthcare settings, not just in the mental health setting. So we did integrate that into the first semester of the program. Trauma informed, we weave that in throughout all of our simulations. We talk about a trauma informed approach. We have lectures based on trauma informed approaches in our first foundational course, and then again, sort of coming back to it throughout the clinical courses. So yes, we have woven that sort of integrated it into the various simulations in the program. Hopefully that answers.
Any other questions before we conclude with the session?
I'd just like to say that I wish we'd had this 60 years ago when I was a student nurse at U of T, and we only had a Mrs. Chase and our classmates to work on. This
Yep.
is terrific. I've been retired for almost 30 years, and I still love knowing about teaching and hearing the new things that are evolving. So this was very interesting. Thank you.
Thank you for that. We still have them. We'll practice on each other, by the way, so.
Well, in closing, I just want to thank everyone for joining us today. We really appreciate it. And thank you again, Erica, for taking the time to share your work with our community of alumni and supporters. Enjoy the rest of your day, everyone. Please stay warm this cold, snowy day, and have a good rest of the day. Bye for now.